time for what seems to be an endless number of Puscasts. This one covers the first 2 weeks of August in the year 2019, reviewing infectious disease literature that I find either interesting or entertaining. References, as always, are available at EdgyDoc, where you will find links to my multimedia empire of podcasts, books, apps, lions, tigers, and bears. Oh my. Also, my usual warning in the summertime, I'm doing this podcast on the front porch on a beautiful evening in the Great Pacific Northwest, so you may hear crows or cars, and I'm sure you'll hear some goddamn barking dogs. Seriously, is there such a thing as a good dog owner? I don't think so. Send your hate mail to mcrislip@mac.com. Let's move on to the literature, shall we? Bureaucracies often exist to make simple things complicated. Take hand hygiene. The World Health Organization figures that the hand hygiene needs 6 steps, and consequently, people are not compliant. Someone compared the World Health Organization protocol with a 3-step protocol. The 3 steps being 1, covering all surface of the hands based on own judgment, 2, rotationally rubbing the fingertips and the palms of the alternate hand, and rotationally rubbing both thumbs. Jesus, even that seems excessive. Basically, just slather your hands with foam and your stethoscope, and that should be more than enough. But in this study, they compared the unbelievably complicated 6-step to a simpler 3-step and found people were more adherent with hand hygiene. I've written about this before, but we have a very simple recommendation in my institutions. You foam when you walk in a room, you foam when you walk out of a room. If you do that, you're going to prevent the transmission of organisms in the hospital, and it's fairly simple to do. Foam in, foam out. Slather your hands and your stethoscope with foam. I can say that as a result, our nosocomial infections have vanished in my institutions, so I suspect it has been effective. Even the 3-step seems kind of silly, at least to me. I spent 10 years writing an essay every other week over at Science-Based Medicine, covering, among other things, the anti-vaccination movement. And one of the things I noticed in that decade is how little involvement the Infectious Disease Society America had in combating the anti-vaxxers. I mean, basically nothing. I don't go to every ID week, thank God, but the ones I went to never had a symposium devoted to the anti-vaxxers. And there has been only one article covering the anti-vaccination world published in Open Forum Infectious Diseases, which means probably the author had to pay to have it published. There was no note that it was done as a freebie. Finally, CID has a nice review on myths associated with vaccinations. Way too little and way too late, at least to judge from the measles epidemic ongoing in the United States right now. I always supposed that they were scared off by the brouhaha over Lyme disease, but what do I know? However, if you need 2 nice reviews on vaccinations, I recommend the Open Forum Infectious Disease article a couple of years ago and the current article in Clinical Infectious Diseases called Principal Controversies in Vaccine Safety in the United States. Generally, I find inflammatory markers to be a waste of time. About the only time I order Cedrates is if I'm worried about temporal arteritis or polymyalgia rheumatica. I never order C-reactive proteins. I believe that the appropriate acronym is CRAP, nor do I ever order procalcitonins, because as best I can tell, they never really alter therapy. And if you're going to spend your patients' money and drive them into bankruptcy, you better use the tests that you order. There is a recent article on AIDS patients that looked at the soluble urokinase plasminogen activator receptor And it turns out that in AIDS patients, if it's elevated, it predicted non-AIDS related events in AIDS patients. What is a soluble urokinase plasminogen activator receptor? Well, according to the article, it is, quote, a marker for monocyte T cells and plasminogen activation. And when it was elevated, it predicted mortality and morbidity in AIDS patients. To which I respond, who cares? Unless you can use it to some way modify patients' behaviors and subsequent risks, all you're doing is spending money to make physician and patient anxious, like SED rates and CRPs. Another interesting test which, to my mind, has no clinical utility. Boy, I'm starting out on a real grump fest this time. Perhaps I should call this podcast the Grumpy Old Doctor Podcast. So, what is the effect of influenza on pregnancy? Certainly, fetal loss is on the list. And there was one interesting study to suggest that babies born during flu season were not as bright as children born outside of flu season. Now, that's my interpretation. The study showed that kids born during flu seasons tended to have a slower lifetime income compared to those born outside of flu season, which I interpreted as the babies were born not as bright if they were born during the flu season. Now, that's my interpretation. Remember, you can send your hate mail to mcrislip@mac.com. This study looked at modern data on the risk of influenza in pregnancy, and they found that it was associated with hospitalization, but they did not find higher mortality or a higher likelihood of ICU admission with pregnant women who had influenza. Although the 7-fold higher admission may be due to the fact that they were pregnant, so rather than severity of illness, they were admitted because, well, they're pregnant with flu. So while other studies have shown increased morbidity and mortality in pregnant women with influenza, this study did not. One of the features, if you would call it a feature, maybe you'd call it a bug, of this podcast is I tend to talk about things that interest me and affect my practice. The result of this is that I have pretty much ignored hepatitis C. That probably is going to have to change, as I've been informed that, yay, I need to be involved with the treatment of hepatitis C in my hospital systems for a variety of reasons. So I'm going to have to learn about hepatitis C and its treatment. One of the things that did pop up this week, which I did not know, and you might be hearing more hepatitis C stuff going forward, is that patients with hepatitis C, specifically men, have low testosterone levels, both during their disease and after treatment. And evidently there is a well-known association between chronic viral infections of the liver, hepatic dysfunction, testosterone metabolism, and hypogonadism, all of which I am unaware of. And never forget about hepatitis D. For some reason, I think of it as an Italian disease. If my memory is sound, most of the initial reports came out of Italy. Just how common is hepatitis D in the United States? Well, remember that hepatitis D, the Delta virus, requires chronic active hepatitis B to multiply. It's a virus of a virus, which is way cool. This study found it was not that uncommon. In patients that were hepatitis B surface antigen positive, 42% had antibodies to the Delta virus. So that's nearly half for those of you who can't do arithmetic. And the ongoing delight that is traditional Chinese pseudo-medicine. There's an herbal medicine from China that contains aristolochic acid, if I pronounce that right, aristolochic. And if you take that and have hepatitis C, you increase your risk of carcinoma of the liver. Generally speaking, however, it's a good idea to avoid all herbal products because, one, they often have real medications in it that you're unaware of, and two, what's on the label is not necessarily what's in the tablet. If anything, you're probably better off just randomly grazing in your backyard. Eculizumab, if I pronounced that correctly, is a monoclonal antibody that inhibits terminal complement activation. It binds to complement protein C5 and prevents cleavage into C5a and C5b. It's been well known for a long time that this medication increases the risk of meningococcal disease roughly 1,000 to 2,000 fold, the complement pathway being critical in the control of Neisseria meningitidis, but also Neisseria gonorrhea as well. And there is a series of cases in a clinical infectious disease paper of disseminated GC in patients on that medication, most of whom are quite sick. This medication is given to patients with paroxysmal nocturnal hemoglobinuria, atypical hemolytic uremic syndrome, and your favorite and mine, anti-acetylcholine receptor antibody positive generalized myasthenia gravis. I actually don't think I've seen any of the above in my career, although I did see one patient who was placed on the medication and they were asked to see me in terms of meningococcal vaccination. So when you think eculizumab, think disseminated meningococcus and gonorrhea. That has to be a board question coming up. I have found the effect of the pneumococcal vaccine to be interesting since it is fundamentally applied evolution. So the first thing that happens in populations of children, and this is in Bedouin and Jewish children, with the pneumococcal vaccine, is that there is a decrease in the nasal carriage of the strains covered by the vaccine. Great. Then what happens is other strains move in to fill that ecological niche, but interestingly, not at the same rates as the prior strains, so the overall colonization of pneumococcus decreases in these populations. The replacement strains were initially antibiotic susceptible, but being exposed to antibiotic pressure in the community, they subsequently became more resistant to antibiotics. And what's nice about this study is where these features have been described in isolation over time, this is a study that has demonstrated these effects of the vaccine in a very controlled population. Jewish and Bedouin children in Israel that, quote, live in separate locations and attend different educational systems. Evidently, there's little intermix between the two populations, demonstrating the same evolutionary process in two separate groups. Makes this even a cooler study on the natural history of pneumococcus as a result of the use of the vaccine. From a practical point of view, we tend to think that patients either have MRSA infections or MSSA infections, but actually it's far more complicated than that. There are two studies in the literature, one out of China and one out of France, that basically show the same thing, that new strains of MSSA, in this case, enter into a community, widely disseminate to cause disease. In France, it was the clonal complex 398, while in China, it was a clone of PVL positive ST22 MSSA that entered the community to start causing disease. So what likely happens from time to time is new strains of MRSA enter a naive community and then spread, causing disease for a period of time. And I would bet you can likely expect waves of Staph aureus infections, both MSSA and MRSA, due to new clonal populations over time. Again, evolution in action. In determining how long to treat somebody with staph bacteremia, I've always doubled the duration of therapy in uncomplicated staph bacteremias in my diabetic patients, especially if it's MRSA. The data would suggest that diabetes is a risk factor for more complicated disease. This is confirmed again in this study in the European Journal of Clinical Microbiology and Infectious Diseases that showed that being a diabetic doubled the risk of a metastatic infection with Staph aureus bacteremia. And while diabetics did have a longer length of stay, they did not have increased mortality rate. But diabetics do better when treated aggressively for their Staph aureus bacteremias. And speaking of diabetics, I always perseverate about pharmacokinetics. Is the antibiotic I'm giving getting into the tissue where the infection is? This study looked at the concentration of daptomycin in diabetic bones and found the concentration was quite nice at the 6 milligram per kilogram dose, with levels of 4.5 to 40, nicely above the MICs of the staph and enterococci in the series. Although they note that for enterococcus, it's often right at the cutoff. But the nice thing about getting good bone levels at 6 milligrams per kilogram, it's certainly less expensive than the 8 to 10 milligrams per kilogram you should probably be giving daptomycin for endovascular infections. And perhaps another reason to avoid vancomycin, whose penetration into virtually all tissues is somewhere between diddly squat and nothing. But then I'm always looking for a reason not to give vancomycin. Pharmacy hates me for that. One of the recurring themes of the infectious disease literature is how badly people treat infectious diseases who are not infectious disease specialists. I've always wondered how the world would react if cancer was treated in much the same way that infections were. For example, in this study out of France, they looked at the effect of antibiotic choice on enterococcal bacteremia. And they found in their enterobacteremias that 43% of empiric antibiotic therapies were inefficient for enterococcal bacteremia. Okay, I can buy that. Empirical antibiotics are always a crapshoot. But 17%, almost 1 in 5 of documented infections had the wrong antibiotics on board for the enterococcal bacteremia. Can you imagine if people treated 1 in 5 cancers with the wrong chemotherapy? Good God. But the other take-home of the study was that patients did best when they were placed on ampicillin/amoxicillin, even when compared to other antibiotics with some enterococcal efficacy. It is rare indeed when I see a patient with enterococcal infections to be on ampicillin or amoxicillin. They're always on vancomycin or linezolid or something else. But the take-home from this study is amoxicillin/ampicillin is the best antibiotic for treating enterococcal bacteremia, and I think all enterococcal infections, with the caveat, of course, that it's sensitive and the patient doesn't have allergies. But again, yet another study to show what a crappy job doctors do in treating serious infections in the hospital. One of the things that has always kind of bugged me, you what? Something bugs me? Are you kidding? But semi-seriously, it's always been sort of annoying that when patients get protocolized therapy, instead of having physicians do a history, physical, and cognate on the problem, that patients do better when doctors are thoughtless. Outcomes for most common diseases tend to be better when people follow a protocol. This has been demonstrated for several diseases now, including sepsis. And they found that in New York, that the use of mandated protocolized sepsis care was associated with a greater decrease in sepsis mortality compared with sepsis mortality in control states that did not implement sepsis regulations. Because baseline mortality rates differed between New York and comparison states, it is uncertain whether these findings are generalizable to other states. Yeah, they probably are. I suppose that following a protocol makes sure you don't forget important things. And the flying spaghetti monster knows it's easy to forget important things in medicine, and ensures that the patient does receive state-of-the-art best opinion care. But still, it kind of bugs me. I remember that one of my reviews for my Quackcast said that my podcast was, quote, bad for the Brian. Sepsis is also bad for the Brian. Wait, that's bad for the brain. In that it induces moderate to severe vascular brain injury when they did studies looking for microvascular infarcts. And the more severe the sepsis, the more the microinfarcts, especially within part of the brain that makes us us, the cerebral cortex. Part of the reason why some patients who come in septic are never the same again. And those of you who are regular listeners know that I like meta-analyses when they confirm my pre-held biases, and I can dismiss them as flawed when they don't. This one confirms my pre-held bias. They did a meta-analysis on the benefit of procalcitonin-guided antibiotic therapy in critically ill patients, and overall did not find that it helped decrease mortality or length of stay in patients with sepsis. As mentioned before, I don't think I've ever ordered procalcitonin because we don't have it in our hospitals. In part because I think it's a waste of time in the real world, which has been supported by real world analyses of the use of procalcitonins. They tend to get ordered, but they don't enter the cognitive algorithms of the prescribing physicians. I tend to think of streptococcal prosthetic joint infections as easier to take care of. My biased memory is that relapse of these infections tend to be rare because you can often kill a strep. However, there have been 2 studies out to show that's not true. The first one was a couple years ago, if I remember right, in open form infectious diseases. And this one out of Denmark suggests that streptococcal infections do poorly, and that if you do debridement and antibiotics and implant retention, that the failure rate, the relapse rate, is 51.4%. And patients did much better if they had a 1 or 2 stage exchange. They also found that group B strep was the worst of the bunch. The other common organism was Strep disgalactiae. And in contrast to the other study of streptococcal prosthetic joint infections, they did not find rifampin to be of benefit in treatment. Like I say, I don't think I have that high a failure rate. But then I call my wife Hun so I don't have to remember her name. Similarly, I call my children Son. Which one's Brad? Which one's Jeff? That's too hard to remember. So perhaps I've had a lot of streptococcal prosthetic joint infections that have failed. I just can't remember them. But as best I can tell with this study out of Denmark, most patients were not put on chronic suppressive oral antibiotics, and I put everybody with a prosthetic joint infection on chronic oral suppression. So maybe that's the difference. And the other thing in this study is most patients got 14 days of IV therapy followed by oral amoxicillin therapy, sometimes alone, sometimes in combination. Now, the recent New England Journal study suggested that oral therapy is as good as IV therapy for a wide variety of osteoarticular infections, but maybe that's not so with a streptococcal joint infection. My tradition, for whatever it's worth, is to give everybody 6 weeks of IV before switching over to oral. Maybe that's overkill based on some literature. Maybe that's conservative therapy. But the short course of IV and the lack of chronic suppression may explain the relatively high failure rate for the high failure rate of their attempt at salvaging prosthetic joint infections with streptococci. Again, imagine if we treated cancer like infectious diseases. This study looked at the practice of physicians and nurses as it relates to getting urine cultures in catheterized patients, and they analyzed how closely they adhered to the IDSA guidelines. Guess what? They didn't. 86% of the time. That is god-awful. One of the reasons for inappropriate culture of urine was a change in odor or color. The former I would only believe if you were a beagle trained to sniff out urinary tract infections. They also note the lack of utility of the pan culture in a febrile patient that includes a urine culture. And doing these inappropriate urinary cultures in patients with catheters was not without harm. Quote, 20 cases experienced partial or delayed management of other infections, drug adverse events, and Clostridioides difficile infections. And that was 11% of the patients had an adverse effect from the inappropriate culture. Maybe that's why people get better care with algorithms. People come in sick, and initially you have to kill what's going to kill your patient. And in this era of antibiotic resistance, that often means something like Zosyn and vancomycin, or cefepime and vancomycin, or carbapenem and vancomycin. The important thing, however, is to get the patient off the anti-pseudomonal ASAP. This is for several reasons, cost, of course, being one. But 2 studies out this month show that the longer the patient is on an anti-pseudomonal beta-lactam, the more likely they are to get C. difficile. And the longer they're on an anti-pseudomonal beta-lactam, the more likely they are to become colonized with carbapenem-resistant organisms. The more narrow the antibiotic, the less the selection pressure on the microbiome and the environment of your patients. Again, remembering that infectious diseases is in large part applied evolution. Again, alcohol is bad for you, at least in excess. I'm not inclined to cancel my saloon box prescription anytime soon. This study looked retrospectively at the effect of alcohol use on patients with meningitis, and they do worse. Quote, compared with non-alcoholics, chronic alcohol abusers are more likely to present with seizures, altered mental status, higher SOFA score, and have an increased risk of an unfavorable outcome. Not a surprise really, but it does confirm what we already know clinically. There's this whole interesting literature on the hygiene hypothesis, and that being exposed to pathogens may help with a variety of infections. There's also that curious literature on treating inflammatory bowel disease with gastrointestinal parasites. I have at best a cursory understanding of the processes involved, and I find it interesting, but I don't keep up with it actively. This interesting study, however, showed that strongyloides had a beneficial effect on type 2 diabetes, as judged by a variety of chemical parameters, and that when they treated the strongyloides, the diabetes got worse. Biochemical data that backs up epidemiologic studies that show that those who are infected with parasites, gastrointestinal parasites such as Ascariasis, hookworms, Stercuris, and strongyloides, are less likely to develop type 2 diabetes. And there's even a clinical trial I found advertised on the web where they are going to use hookworms to see if they can modulate type 2 diabetes. I haven't done a search yet, but a nickel says that there's going to be an alternative medicine, probably the naturopaths, ND standing for it, not doctor, who are soon to offer this in clinics across the country. A natural cure for diabetes, parasitic worms. Yay! But it's still fascinating stuff. And they point out that the deworming programs in third world countries may result in increase in type 2 diabetes. And you know the motto, no good deed ever goes unpunished. And that's it, the end of the Puscast. This one covering the first 2 weeks in August in the year 2019. References are available at edgydoc.com and are embedded in the podcast itself. Otherwise, at edgydoc.com, you can find links to my multimedia empire of books, which you can purchase on Amazon, hint, hint, my other podcasts, my apps, and my blogs. Otherwise, as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation, and take it away, Jeff.